Good afternoon, everyone. My name is Luke Brand. I'm the Strategic Director of the American Cancer Society's National Prostate Cancer Roundtable, and I'll be your host and moderator for today's session, which is covering some special care considerations in the treatment of advanced prostate cancer. The landscape of available tools for the treatment and management of advanced prostate cancer is rapidly changing, and lots of advances have been made over the last 6 to 10 years that have really required a lot of optimization in terms of their combinations combinations and the sequencing of the therapeutics that we use in the clinic. But with more potent and effective treatments often come more potent side effects, which can have implications on the patient's ability to remain on intensified treatment regimens. So today we're going to hear from three special guests that are going to help us understand some of these special considerations a little better and how we can address them in the clinic. From the treatment of older or frail patients, the safeguarding of bone health, and the potential for cardiovascular disease in patients undergoing systemic therapy for metastatic prostate cancer. While this isn't an exhaustive list of concerns faced in this setting, this webinar will begin an ongoing conversation through the Roundtable's priority teams on optimizing supportive care across the prostate cancer continuum. And so before we get started, I would like to take a moment to thank our sponsors for today's webinar, Pfizer and Bayer. Their partnership is really, really critical to both the making of today's webinar and the ongoing work of the National Prostate Cancer Roundtable. So thank you to these organizations for their support. Few ground rules for today's event. First, the ACS and ACS CAN are nonprofit, nonpartisan organizations. We believe everyone should have a fair and just opportunity to prevent, detect, treat, and survive cancer. So we're asking that everybody please avoid partisan discussion today. We do have a rules for engagement document that outlines our commitment to kindness and to collegiality at our events. These rules for engagement are viewable on our website at any time, but it really comes down to the idea that we're all working toward the same goal. So our interactions should mirror that commitment. Finally, today's webinar is being recorded, so please, in the Q&A session and discussion, please refrain from any identifying information for patients and things like that. After the fact, this webinar will be archived on our website. It will be viewable in perpetuity. Everybody is muted and video off. We'll try to have everybody stay that way except for our speakers. And we're doing this obviously on the Zoom platform. So if you have any questions about their privacy policy, you can find it on their website. If you have any questions, we will have a discussion period at the end of today's presentation. So please type them into the question and answer box at the bottom of your screen. And you can also use the chat to comment on things or ask questions as well. So before we get into the meat of today's presentation, we had some prior programming that may be important to frame our discussion today. First, we hosted a webinar on these recent advances in clinical management of advanced prostate cancer back in September. That conversation laid some of the groundwork, so we won't be covering specifically the new therapeutics, combinations, or imaging modalities that are available in this setting. That was covered in this prior webinar. So if you have any questions about that, that one is also on our website, and you can view that at your leisure using that QR code on the screen there. That webinar led into our summit on advanced prostate cancer. And that summit, in that summit, we discussed a wide array of topics, including the ones that you're going to hear about today. And these have been integrated into our strategic roadmap, which is going to inform the work of the roundtable going forward. So before we get into learning objectives. Yes, so the summit also set the learning objectives for today's conversation, which, as I mentioned previously, focus on the treatment of older or frail patients, how to manage cardiovascular disease in this setting, which can stem from the treatment with systemic agents in advanced prostate cancer, and then finally preserving bone health and minimizing fracture risk in this setting. Our ACS team underlying this webinar, just a quick introduction here. Our Vice President of the National Roundtables and Coalitions Business Unit is Sarah Schaefer. I'm the Strategic Director of the Roundtable. And then we have Michelle Chappell supporting us from behind the scenes as our program manager and producer today. Michelle has obviously excellent taste in vacation destinations, so I'll be leaning on her for recommendations for my next PTO. Before we start the talks, we have a little knowledge check that we'd like you to fill out for us. 3 questions, so we'll give you a couple minutes to do that. Just give you a couple minutes to fill that out, and this will help us gauge how well we hit our learning objectives today. All right, looks like people are getting to the end of that quiz. So please continue to feel free to continue to fill that out if you're not finished yet. I'll start leading into the next section, which is introducing our speakers for today. First up, we will have Dr. Alicia Morgans, who is a genitourinary medical oncologist and an associate professor of medicine at Harvard, as well as the medical director for their survivorship program. At Dana-Farber Cancer Institute. Dr. Morgans is going to be covering the topic of caring for older patients in today's webinar. Up next, we'll have Dr. Chuck Ryan, who is a leading GU medical oncologist at MSKCC. Dr. Ryan will be covering the preservation of bone health. And then finally, but certainly not least, Dr. Avi Guha will be covering our director of cardio-oncology program at the Georgia Cancer Center and assistant professor of medicine will be covering the cardiovascular angle and how to preserve cardiovascular health in prostate cancer patients. Quickly popping up our disclosures slide here for your review. And then I will turn it over to Dr. Morgans to start the discussion.
Great, thank you so much. And I'm just going to share my screen so that we can have a smoother conversation with everybody. All right, let me shrink some stuff down so I can see. Okay, so I'll be starting off really thinking about some of the special considerations for treating people with advanced prostate cancer who, when patients are older adults, and some of the considerations that we make to try to ensure that they get a treatment that can match the aggressiveness of their cancer, but take into account the rest of the person and ensure that everybody is safe. And these are my disclosures, as you just saw on a couple slides ago. And so why is this so important in prostate cancer? I think this is really critical for us as a prostate cancer community because the majority of our patients are going to be potentially older adults. The median age of diagnosis, as we can see on the right hand of this slide, is 68. And that number has been creeping up ever so slowly, but ever so consistently over the last number of years. On the left-hand side of this slide, we can see that there is absolutely growth in the age group of older adults in terms of the cancer survivor population as it is and as is expected through 2040, with the population between 65 and 74 and 75 and 84 actually making up a large portion of the survivor population and certainly being older adults. As we think in clinic about taking care of people who are older adults and all people with prostate cancer, I think one of the most important things that I consider is that chronologic age, the number on the birth date, is very different than biologic age. These two constructs are really important to sort of pull apart and understand because the individual who's getting the treatment, the individual who's working in clinic and with their families to do the best that they can in terms of their prostate cancer care and the care of the rest of their health is going to be affected very differently by these two numbers. As we can see on the screen here, these gentlemen are actually approximately the same age. Both of them are about 74 years old. And the gentleman on the left is being extremely physically active, has a lot of musculature, upper body, lower body, certainly is doing all that he can to maintain that physical function and strength. And the gentleman on the right, absolutely, doing well as well, but maybe requires some assistance in terms of completing medical forms, has a walking device to have assistance to get around and reduce risk of falls, may have other medical problems that are also affecting him. And so he's in a very different situation than the gentleman on the left. So as we're making decisions about how to apply treatment, I think we have to consider the life expectancy of someone, and that's where we really think about their biologic age. These are life expectancy tables that help us think about how much time someone is estimated to have left based on their physical function. And for those patients who are in the top 25th percentile of their age range, they may have, when they're in their 70s, 18 more years of expected life, where we have somebody who's maybe in the bottom 25th percentile of life expectancy for his age, comorbidities, and other medical problems, closer to 7 years of expected life. And there's a big difference between these two quartiles, and really there should be a difference in the way that we approach and support patients when they come from these different worlds. There is a group, an organization, an international organization called the International Society of Geriatric Oncology. Its abbreviation is SIOG, and they try to help us in the cancer community think through how do we best address patients and their needs when they are older adults. And they've made specific guidance for individuals with prostate cancer. And they really suggest that we work through this algorithm on the right-hand side, which I'll explain in just a moment, to try to stratify our patients' fitness and then tailor supportive medicines to them and effectively inform their treatment decisions by making sure that we support them adequately and get them the interventions they need to perhaps ensure that they can get even either whether it's more intensive treatment or less intensive treatment, depending on how they come out. So they suggest screening with a geriatric assessment called a G8, which is a relatively simple set of questions that I'll get to on the next slide, as well as a mini-cog, which is a 3-question assessment of their basic cognitive function. These are not in-depth and super detailed assessments, but are screening assessments that help us, in short order, come to some basic conclusions so that we can more intensively screen people who seem to have deficits. As you can see on this algorithm, if patients score over 14, they essentially are really in a fit sort of category. They don't need further geriatric assessments, and they can probably get whatever treatment, whatever intensity of treatment is appropriate for their cancer. On the right-hand side of this algorithm, if they score less than a 14 on the screening G8, we break them down into having reversible deficits or irreversible deficits, where if somebody has reversible deficits and they fall into this frail category, we want to provide whatever supports may be necessary to try to help move them closer to the fit category or support them in their frail category to get whatever treatment is appropriate. So this might be referring them for physical therapy or trying to reduce polypharmacy or whatever that deficit is, trying to make sure that we address that to, again, keep them safe, keep them well, and give them the right treatment. Now, if they have irreversible deficits, they're really having more needs, they may be in a position where minimal treatment is going to be the right thing for them, and ongoing support for them and their family is of course, critically important. So this is the G8 screening tool, 8 questions, relatively simple to administer quickly in clinic, even as patients are checking in, if that's the workflow that the clinic has come up with. It's asking about things like food intake, weight loss, mobility, neuropsychiatric questions, whether they're having polypharmacy, more than 3 medicines in a day, and how they perceive their fitness in comparison with others of their same age. So why is this important? Well, we have multiple systemic treatments that we like to give to people with prostate cancer in order to control their cancer. And certainly these treatments come with their own side effects and risks and their own complications, particularly in that they can cause people to lose muscle mass, have increased fatigue, perhaps have some mobility or gait instability. And so we really need to understand, are these treatments going to be worthwhile in our older adult population? The most commonly used treatments beyond standard androgen deprivation therapy for patients with prostate cancer are the androgen receptor pathway inhibitors. These are medicines like enzalutamide, abiraterone, darolutamide, and apalutamide, medicines that block testosterone signaling through the testosterone receptor and are highly effective for the treatment of prostate cancer. Well, do they work similarly in our older adult patients? Should we go through the trouble of giving them extra medicines? Is it worth it? So when we think about the metastatic population, where these are very standardly used, there have been multiple analyses that have tried to understand, do these drugs work as well in people who are older than they do, or as they do in people who are younger? And for one of these medicines, one of our tried and true called abiraterone acetate, absolutely these drugs seem to work as well in older adults as they do in a younger population. And Titan is a separate study also in the metastatic population looking at apalutamide. Again, older adults seem to benefit similarly to the younger population when receiving this medicine. So really reassuring that we can use this with effectiveness across the age range. Enzalutamide, another one of our tried and true androgen receptor pathway inhibitors, also seems to work as well in our older adult population as we see in our younger patients. So again, very reassuring. But one thing that came to light about a year ago, maybe 2 years ago at this point, is that we do need to be cautious and think about these drugs really specifically in older adults, and do the analyses to actually get the data to understand their effectiveness. This study was specifically looking at abiraterone, which was the first drug that I showed you, versus enzalutamide, apalutamide, and darolutamide, which are slightly different mechanism in terms of blocking the testosterone receptor. And when they looked at the younger age group, which they defined in this analysis as less than 75, they found that there were really similar benefits in terms of progression-free survival, so progression of disease on scans, and overall survival, survival for measured just within these clinical trials. In the younger age group, both of these were the same. Younger age group, abiraterone and the other amides were all similar. When they looked at the older age group, 75 and older, they found that the amide group, the darolutamide, enzalutamide, and apalutamide, seemed to also have similar effects in terms of progression on scans and overall survival. But when the abiraterone was assessed in this area for the older age group, maybe less of a benefit for progression on scans, and maybe not a benefit that was clearly measurable when it came to overall survival. Now, I would say this is hypothesis generating. This is not telling us that we cannot use any of these drugs or should use any of these drugs in our older adult patients, but it absolutely, I think, has given the field a little bit of pause when they're thinking about the risk-benefit ratio of using these medicines. The other thing that I think is important here is that these effects that are important to patients do not stop at cancer control. There are things that are important for older adult patients, actually for all of our patients, beyond simply does the cancer grow on scans and does this make me live longer? We also think that it's very important for individuals to have a quality of life that is meaningful to them. And we appreciate when they have data, such as the data displayed on this slide, that helps us understand as clinicians what is the real experience like for somebody living with this prostate cancer, undergoing these treatments. These curves represent the quality of life by patient report and their overall quality of life, how they're feeling in various different domains. And the basic message is that on the left-hand side, patients who are under 75 reported that their overall quality of life, whether they were taking the medicine, the blue line medicine, which is abiraterone, or taking the red line medicine, enzalutamide, their quality of life was overlapping. It was very similar for those patients under 75. Whereas for patients over 75 in this particular trial, when they were taking the abiraterone blue line medicine, they had a better quality of life or reported a better quality of life than they did when they were on the red medicine, enzalutamide. So we only saw this difference in people over 75. It just gives us pause, something to think about. Finally, I do think that a consideration for older adult population, as for all of our patients, is that there can be financial toxicity with our treatments, particularly in a population that often is on a fixed income. This was a study of over 500 patients who had advanced cancer of different types, and these patients reported that financial toxicity was a real concern, and many of the patients included in this analysis had prostate cancer. For those patients who reported financial toxicity, they had higher rates of depression, anxiety, distress, and poor overall quality of life. So when we think about this in terms of the direct costs of medical care, the indirect costs like loss of time at work or increased burden because someone else has to now take care of your family member who is also dependent on you, or other economic challenges, these are really important things for us to think about, to ask about in our older adult patients. So to sum it up, prostate cancer disproportionately affects the older adults that we see in our clinics, and the older adult cancer survivor population is growing around the world. Older adults should have assessments that properly define their risk of complications and identify these reversible areas for supportive interventions like physical therapy, reduction of polypharmacy, or whatever it is that they need to enable them to undergo effective treatment. Disease control and quality of life outcomes do suggest similar benefits for older people if we can treat them safely. So we do need to get them the therapies that they can benefit from. And financial toxicity should be considered as a source of potential distress and opportunity for intervention for our patients. Thank you so much for your time. That wraps up my section.
Thanks so much, Dr. Morgans. At this point, we'll turn it over to Dr. Ryan to take us through bone health in advanced prostate cancer patients.
All right. Well, hello, and thank you everybody for joining today, both those of you joining live and watching the recording. I'm going to talk about bone health, which is an issue that has been a challenge for prostate cancer patients forever. And we do have a number of therapies that address bone health, but we do have unanswered questions, and we do have special populations and special challenges in their implementation. Okay. So why do we need bone health? It's pretty obvious. This is a MRI scan of a person who's had a fracture in their thoracic spine. Bony morbidity not only causes suffering for its own right, it is painful, it is debilitating. It also is a predictor of mortality. Patients who are immobile, who fall, who have fractures, they have a worse quality of life and they have a worse survival. Symptomatic bony events, when they occur, they lead to loss of function and pain. We also have a unique setting in prostate cancer in that this is a disease that affects bone that we treat with a treatment that affects bone. Androgen deprivation therapy leads to osteoporosis, even in patients who do not have bone metastasis. So one can imagine sort of the double effect, the double whammy that we see in patients with a burden of bony disease that could lead to fractures and debilitation, coupled with the therapy that can thin the bone. We also use a lot of steroids, especially as this disease worsens over time, and steroids can empty out bones, can lead to problems like hip fractures and other things. And while I say it on the bottom, we have reasonably effective treatment approaches to prevent events, preserve function, and maintain quality of life. We just need to make sure they are used. And this is an unexpected and very common challenge in our practices. Next slide. So here's what we have. We have really stable. We have we have supplementation with calcium and vitamin D that I really recommend. I'm sure my colleagues do recommend vitamin D supplementation for all patients receiving androgen deprivation therapy. It's also important to consider checking a vitamin D level. Um, uh, Men in northern climates, especially white-skinned men, have a higher likelihood of having vitamin D deficiency, which can predispose one to fractures. So we want to check that at baseline. Um, and then we have two drugs that can be used in sort of two different ways for two different purposes. Remember, I said we have the disease affecting the bone, and we also have the treatment affecting the bone. So with zoledronic acid, you have a drug that's called Zometa, which is 4 milligrams that can be given really every 3 weeks to every 12 weeks. It can be given with chemotherapy and with other medications, and that is to prevent skeletal related events. That is if you will, a high dose of zoledronic acid. And what that does is it actually forces calcium in the blood into the bones, fortifying bones, preventing fractures, preventing the disease from exerting significant negative effects on the bone. The very same drug, zoledronic acid, can be administered 5 milligrams once a year for osteoporosis treatment. And that treatment has been shown to improve bone density for patients who have lost bone density due to the androgen deprivation therapy. Note that the 5 milligram once a year dose would not be sufficient for a person who has a significant burden of bony disease. It's not going to have the same skeletal related complication from the disease prevention issue. Intravenous therapy is the other key point. Denosumab, similar to zoledronic acid, is two drugs, really. Xgeva is the trade name, given similarly for Zometa. Now, this drug is administered subcutaneously, has essentially the same effects, maybe slightly more potent effects and skeletal-related event prevention. We use them relatively interchangeably. We can give Xgeva in the clinic. Our nurses can give it during a clinic visit. Zoledronic acid given intravenously requires obviously a chair and a chemotherapy suite and intravenous drip capabilities. Prolia is also denosumab, very similar to reclassed, if you will. That's given every 6 months for osteoporosis treatment. So we have that. But now I'm going to also talk a little bit about where we're going with prostate cancer because we have radium-223 and we have other radioligand therapies, which actually bring radiation and other potential benefits to bony disease, but other potential downsides to underlying bone health. Next slide. So what we have is these therapies that are available. These are FDA-approved therapies. These are standard. They're typically covered by insurance. They're typically very well tolerated. There's very little reason to not use them, except for in a few settings such as kidney insufficiency and things like that. And in both cases, CRPC patients, or androgen pathway modulation resistant, as we're about to start calling it, patients should be receiving some sort of bony protective therapy if they have bony disease. It's not optimal use. My colleague Aaron Mitchell here at MSK has studied this, and he demonstrates that about 2/3 of patients who should be getting a bony targeted agent are not receiving that therapy. And you can see in the slide here there are various reasons why patients are not getting it. The most common is that shown on top, which is we do require a dental clearance because of the risk of osteonecrosis of the jaw. In my practice, we don't give the drug until we have a dental clearance. Then that requires a letter from a dentist saying it's okay to give this. And what I do is I send my patients to the dentist and I say, go get a checkup. And if any work needs to be done, get it done. And then once you've healed from that, we can start the bone targeted bone therapy. Other barriers you can see there, which include prioritization, lack of logistical barriers, or inability to afford the treatment, all figure in to the relatively insufficient penetration of this across the spectrum for patients with metastatic castration-resistant prostate cancer. Next slide. So the other thing that I think exciting and worth commenting on is um, uh, bone agents. Sorry, go back to the next slide. This is a study that came out now a couple of years ago, and we're seeing this data evolve. This was a study in CRPC done largely in Europe and South America, but it randomized patients to receive enzalutamide, an androgen receptor pathway inhibitor, standard of care drug, uh, to enzalutamide plus radium-223, or marketed in the US as Xofigo. And what this study demonstrated was an improvement in overall survival, suggesting that radium-223, a bone-targeted agent, has benefits in terms of disease control. And this was the most significant finding we've seen in terms of long-term beneficial outcome in the setting of bone-targeted agents such as this. So not only does it prevent skeletal events, not only does it prevent very significant complications such as spinal cord compression and the need for radiation therapy for pain, patients appear to live longer when they receive these drugs. And that's now a consistent finding. It was demonstrated in patients without enzalutamide in a study called Alsimca, which is about 10 to 12 years old now, and now in combination with an ARPI. So if you're a patient with bony metastatic disease, really the default pathway should be that a bone targeted agent should be delivered in the course of clinical care at some point. Next slide. And I will also just point out that as we go forward, this is a slide demonstrating all of the different radiopharmaceuticals that are coming. And this is a very exciting time. And we are going to push the envelope here in terms of patients surviving longer with good quality of life, better quality of life, and a reduction in complications. But bone-targeted therapies and radioligand therapies, and especially bone-targeted radioligand therapies, may actually lead to greater challenges for bone maintenance agents, and so it's going to heighten the need for these for attention to bone health as we move forward. Next slide. So in our role at the Prostate Cancer Roundtable, we talked as a group of clinicians about the barriers to optimal care and the use of bone agents. I think it's worth passing on to patients what these barriers may be. Talks like this, sessions like this, we hope seek to improve and promote education and awareness of the potential benefits of bone-targeted agents and the cost, both in terms of money, but also in terms of mostly quality of life and years and time lost for patients who have bony events, fractures, etc. The NCCN and other guidelines panels clearly recommend the use of bone maintenance agents, and that is something that we need to think about in addition to closer tracking of the issues around bone health. We're continuing to do research. We continue to do research on agents such as radium-223, and of course the other radioligand therapies that are coming. We need to do more research as a field, I think, on patients, for example, with organ dysfunction. So that would be the patient who has chronic renal insufficiency, chronic kidney failure, those kinds of things. Often they preclude patients from receiving some of these therapies, whereas they may potentially be able to benefit with changes in dosing strategies. And so that's something that we continue to work around. And we continue in events like this and other things that I do and my colleagues do, we continue to address the role of bone-targeted therapy in RLT-treated patients, as well as optimal use strategies. Next slide. So I believe that's my last slide, and we'll come back to it in the Q&A. Thank you.
Thank you, Dr. Ryan. And last but not least, Dr. Gua, can you take us through cardiovascular health and advanced prostate cancer?
Thank you. An excellent talk so far. So thanks for inviting me. So we'll talk about cardiovascular health and advanced prostate cancer. Next slide. So as my colleagues have mentioned, the natural history of prostate cancer is worth paying attention to. And I'm sure several members who are here in the participation group who have had either them or their loved ones being in one of these kinds of prostate cancer. And as you notice, most of the prostate cancer, except perhaps castration-resistant metastatic prostate cancer, has a very high degree of survival. Patients generally survive beyond 5 years pretty regularly, even in hormone-sensitive metastatic prostate cancer. Next slide. So what that means is when they move past the 60-month period, which is focused on the slide on the figure on the top left, the degree of death from cardiovascular disease increases actually across the board in all cancers, including prostate cancer. And on the bottom right, you see that when we cross about a 100-month period in prostate cancer survivorship, the light green bar, which is the cardiovascular mortality, actually increases prostate cancer mortality, which is very important to pay attention to. Next slide. This is data from the Radical PC1 study, which is one of the largest prospective cohorts of men from prostate cancer across 9 countries. This specific study completed in 2023 had about 2,600 men. What we did is looked at five risk factors for cardiovascular disease. From left to right, we have obesity, hypertension, cholesterol, physical activity level, and smoking, which are sort of the 5 risk factors looked at in this specific data set. And we saw that overall, in this cohort, 22% had known cardiovascular disease, and overall, 99% had at least one uncontrolled cardiovascular risk factors across the board. And 57% had poor global risk factor control. In fact, patients with cardiovascular disease who had existing cardiovascular disease, that number was 57% as well. Next slide. So where does this risk come from? So there's obviously men who are older who develop prostate cancer who have existing cardiovascular disease or existing cardiovascular disease risk, on top of which they get several cancer treatments for prostate cancer, amongst which there is androgen deprivation therapy. Several people in the audience have perhaps received these, or their loved ones have received these. We talked about these agents, and these agents increase the risk of cardiovascular disease by increasing hypertension, diabetes, high cholesterol, obesity, and decreasing skeletal muscle strength. There's more and more of these added together in advanced stages of prostate cancer, where patients get ARPIs or triplet regimens, which includes chemotherapy as well. Next slide. This is a specific part of our European Society of Cardiology guidelines, which I recommend strongly to go and check out. It's the citations on the bottom right, but this is specific to the agents and what these agents are at risk for. For example, I'll pay attention to abiraterone because that's been sort of a common question across the board. I'm sure we'll discuss it in Q&A as well. But if you notice that abiraterone, so the way to look at this slide is you'll see the cardiovascular disease risk on the top and then the agent on the left. And you can sort of cross-reference. The bigger the circle is, the more likely those side effects are likely to happen when you receive these agents. Hypertension is common with abiraterone. Atrial fibrillation, which is a common cardiovascular disease, is commonly associated with abiraterone as well. Next slide. This is some data which has been really looked at closely, and this is about the 2 agents which are used for backbone of androgen deprivation therapy based treatment. So the backbones are either a GnRH agonist, which is generally Lupron, Luprolide, Eligard, and GnRH antagonist, which are most recently relugolix and previously degarelix, which is an injectable GnRH antagonist. In these 2 trials, number one was the HERO trial. I'll start from bottom because more people are aware of that. That was a trial which led to the approval of relugolix, where relugolix was compared to Luprolide in suppression of testosterone. It met its primary endpoint. Interestingly, at 48 weeks, it had less cardiovascular events than Luprolide, although that wasn't the reason for the study. It was sort of found as a part of a sort of safety analysis during the trial. Pronounce, which was a trial which was done where they compared degarelix, which is the injectable GnRH antagonist, to Luprolide, and they stopped the trial early because no difference in events in both arms in the middle of the trial, so to speak. What was interesting is when patients were enrolled in a trial which was focused towards major adverse cardiovascular events, which is the Pronounce trial, the overall event rate was half of what is known in the general population. So personal take home was when prostate cancer patients are taken care of by cardiologists and oncologists, oncologist, they do much better than when they're taken care of by oncologist, which was sort of currently the global take home. However, the HERO data was so compelling that the European Society of Cardiology guidelines gave a 2A level of evidence B guideline for GnRH antagonists, which is on the bottom right, should be considered in patients with pre-existing symptomatic coronary artery disease who require androgen deprivation therapy. Next slide. So I'm just going to let this slide play. This is actually a CT scan, which is part of the scans several of you might have received for a PSMA scan, which you receive for prostate cancer. The CT scan is actually a lot useful to me as a cardiologist. So what we see in the CT scan is several things. We see the skeletal muscle in the field of view, and we see a lot of calcification. So on the bottom left is the skeletal muscle, which is a back muscle, and on the right is the calcification. Top calcification is the calcification of the abdominal vessels. Bottom calcification is the calcification of your heart blood vessels. And we see it in like broad daylight. Every time a scan is done, we get to see it very easily. Next slide. So why skeletal muscle is important? This is again a paper from Radical PC1 study where what we showed is baseline skeletal muscle strength. If you remember the two men Alicia showed, who had one who was sort of really strong with perhaps very strong skeletal muscle strength versus the frail person with lower skeletal muscle strength. And if you arrange them in quartiles, which is sort of 4 groups of strongest to weakest, for every reduction in quartile of skeletal muscle strength, major adverse cardiovascular events increased by 24%. This is what that data shows. We also showed in the study that waist circumference was also associated with cardiovascular events at 1 year of follow-up. Interestingly, the reduction in strength was noted both in patients with androgen deprivation therapy and without androgen deprivation therapy, which makes for a very interesting research question about whether the prostate cancer itself causes weakening of skeletal muscle strength. Next slide. So this is data taken from a different cancer, but what it shows is with CT scans, you can use a scientific technique called radiomics, where you can measure the muscles automated way and track it along. And it's been shown that this tracking along skeletal muscles using machine learning techniques can assist endpoints of the cancer when it comes to these aggressive cancers, such as this specific one was gastric and esophageal cancer. Next slide. And this is the relevance of the calcium score. So the calcium score of the abdomen in this specific paper was associated with worse cardiovascular disease in patients with prostate cancer. Interestingly, it wasn't associated with worse prostate cancer specific events. Next slide. And this is the data about calcium score from the heart. So in this study from Europe, they showed that increasing in coronary calcification was associated with cardiovascular events in patients with prostate cancer. Next slide. So what can we do about all these risk factors? So we saw the risk factors which come from androgen deprivation therapy. We saw some risk factors which we can easily identify from your scans. So we use the ABCDE paradigm in my clinic. A is awareness of these cardiovascular diseases which can happen. I use aspirin in patients with coronary calcification. B stands for blood pressure. We try to keep blood pressure control below 130/80, which is the standard guidelines for all men of all age right now, which makes it easy to manage. C is cholesterol management. We follow the American Heart Association's guidelines to keep the LDL cholesterol below 100 and strong smoking cessation counseling. And we actually have a really nice smoking cessation clinic we refer our patients to. Diabetes, D for diabetes, which is the goal is if you have diabetes A1C below 7, or track patients when they develop pre-diabetes or diabetes to start treating them sooner than later. And dietary recommendations from the American Heart Association's Life's Essential 8 guidelines. We actually give that pamphlet to all our patients, which also has the exercise guidelines in it. And the other italicized information is something which we use more and more, stemming from a little bit of research. Like you saw some of the data about the calcium scoring, which is under C. And there are other biomarkers in development, which we'll hopefully see soon. Next slide. So this is sort of what we think the path forward is. So baseline cardiovascular stratification should happen in all advanced prostate cancer patients. So using the ASCVD tool, either the ICOS tool, biomarkers, imaging. We should have an integrated care model with oncology, cardiology, and primary care. You saw the data from the trial where I showed that the event rate had halved in patients with Degarelix plus Lupron. And then lifestyle and exercise intervention to mitigate obesity, sarcopenia, and hypertension will help in overall survival of these advanced prostate cancer patients. And I think we are at the end of, or the last slide, so we should start discussing about the strategic priorities of our roundtable. Thank you so much for your attention.
Fantastic. Thank you all of you for the really, really interesting look at these three important areas. It's pretty clear that it's a very rich area for exploration and research, and lots of good work to be done here to improve outcomes and quality of life for prostate cancer patients. So thanks again for sharing your expertise with us today. We have one question in the Q&A box. Please, if anyone else has any questions to ask, please feel free to drop them in there. But the question that we do have asks, studies have showed that ABI for men over 75 did not promote overall survival. Yet another study said that it was easier on quality of life than the Ide brothers. Please help us reconcile the pros and cons of abiraterone, especially given that it may not be preferable for those with cardiovascular considerations.
Yeah, so thanks for the question. And I'll give my thoughts, and then I will also, I'll see what Chuck thinks, because he was involved with the development of this agent and uses it all the time too. And I'm sure has thoughts here as another medical oncologist. So I think for any of the drugs that we use, it's important for us to kind of look at the data and think about populations. So in general, in populations, maybe it can be harder for reasons that are not entirely clear for older adults to take this and may not have all of the benefits, perhaps because of the prednisone, perhaps because of the effects on the adrenal glands, that we do not see the same effects when it comes to enzalutamide, darolutamide, and apalutamide. That being said, when used in the right patient, I think people can feel well. Prednisone can sometimes help with pain control, and it doesn't cause the fatigue for some of our patients that sometimes we see with enzalutamide, which might be a central nervous system effect, and potentially you could get fatigue from any of these, but that's in general terms sort of what I've seen in my clinic. So I think the important thing here is for us to be aware of these analyses, not that these analyses are 100% for every patient over 75, and also for us to know that we have options in most of our clinical settings where we can choose the one that might be right for our patient. If one of them's not right, we can always try to switch to another. So there's not a right answer for any person. It's just a balance of risk and benefit and considerations on the front end, and then sort of adjustment and manipulation on the back end if a patient needs to change. But Chuck, what do you think?
Yeah, I agree. I mean, it's funny. I was during this call, I got a query on my EHR. I was listening to the lecture, and I got a query about ordering a stress test on a patient on abiraterone. So very timely. I think that Alicia's point is a really good one, is we need to individualize risk. But there is no question that abiraterone does have additional considerations that we need to take into account around to patients. I just explain it as salt retention, which can lead to high blood pressure, loss of potassium, and then that can put an additional stress on the heart. So I take a more detailed cardiac history. I avoid abiraterone in patients with known congestive heart failure. And the good thing is I can afford to do that now because we have alternatives to that approach. And so that's what's nice about having a number of therapies that have relatively equal efficacy across the board. That said, I've treated patients in their 80s and even their 90s with abiraterone without significant problems. So it, again, is something that can be individualized, should be individualized.
Great. Dr. Ryan, I have a question for you. You mentioned the groundswell of radiopharmaceuticals that are coming out of the field, and I'm kind of thinking about that in terms of what Dr. Morgan's presented on our ability to treat older patients. I'm wondering if there have been any studies or any work done on whether these might be more or less tolerable in older patients. Is there any data that suggests whether it maybe would lead to some side effects that may not be so.
So sure. So my talk was more or less focused on bone health, but we could talk about radioligand therapies as a class and the older patients and other considerations. I would say one of the things we need to worry about a little bit more with a lutetium-based therapy is renal insufficiency. And so patients who have baseline renal insufficiency or risks, kidney risks, may be more at risk for cumulative renal kidney problems from the lutetium. So that's a consideration that is probably accentuated in an older patient population. And the other piece is, as we get better at the radioligand therapies, one of the things we might get better at is higher doses or higher energy radioisotopes, actinium, other things, and those may lead to unforeseen challenges with the bone and other things. They look really good in early stage trials. And in the case in Europe, for example, they've been using actinium more potent isotopes for quite some time. But we really don't have the long-term quality of life data in those agents yet, because we really haven't demonstrated their definitive activity in the U.S. population at this point.
Thanks so much. We've got another question in the chat box. So once the patch Stampede RTC results are published, which will show that transdermal estradiol provides survival as good as the LHRH antagonists and agonists, but better quality of life, will you start to offer that to your patients as an option for ADT? If not, why not?
This just came up in my clinic yesterday. I haven't started offering it yet, but I'm certainly open to it. And I looked at the data yesterday with one of my colleagues in a conversation. Alicia, I don't know what your thoughts are.
Yeah, so I would say it's actually not necessarily better quality of life. That depends on the eye of the beholder. It's different quality of life effects, and I have prescribed it for some patients. So I think it's just it's really a discussion around what you prefer to have, because there are breast enlargement effects, as an example, that can be really off-putting for many patients, but you also have reduction of hot flashes and some benefits maybe for bone. So they're different side effects, and the trade-off is going to be more or less favorable for an individual in one direction or another, depending on that. These are also transdermal patches. Some people don't like that. So there are just differences that I think we need to consider. But again, it's really nice to have options, and it's really nice for people to be able to think through and say, I'd rather have this or that. The only other caveat I would make is, I was just talking with a patient about this in the curative intent space. So Stampede's a metastatic setting. There was nice data looking at that in terms of these metastatic populations, and then also in combination with AR pathway inhibitors. But we do not have data in curative intent settings. So in combination with radiation, as an example, I don't have clear data. So I don't recommend this in settings where I don't have data, when my goal is to cure the cancer. And I know I have good solid data with a GnRH agonist or even an antagonist in these settings. When I'm trying to cure the patient in that setting, I do not replace that with this data or with this treatment option, because I don't have the data that I can get similar effects there.
And I'm actually curious. So, Dr. Guha, with this question that we're just discussing, and some of the data that our current ADT strategies are associated with cardiovascular disease, is there any data on whether estradiol might be a better option from a cardiovascular standpoint?
I mean, I think like as a hormone or as a treatment, because I don't think so I've ever sort of seen that. I have seen a lot of men with prostate cancer requesting testosterone therapy, and I think Alicia is probably better positioned to answer that question than me. What I have noticed is for patients who sort of tolerated testosterone in terms of natural history for beyond sort of 2 years and don't have any significant coronary disease, they tend to continue doing better beyond that time, because most events happen in the first 6 months to a year when they get put on testosterone therapy. There's sort of a whole host of research going on about intermittent ADT, etc. And again, those are things which we will see in the future, where we'll be able to show how to minimize some of these quality of life and cardiovascular issues by doing things a little more creatively while not minimizing prostate cancer benefits.
So one thing that hasn't come up, but I do want to mention, this was just reported at GU ASCO. This was looking at hemoglobin A1C, cholesterol levels, fat and versus lean mass, and it was in folks who were getting single agent darolutamide. So this is an AR pathway inhibitor that blocks the testosterone receptor, but patients were not getting simultaneous treatment with a GnRH agonist or antagonist, so they didn't have any medicines turning off testicular production of testosterone. When you block testosterone receptor, but you don't turn off testosterone production, you actually get heightened levels of testosterone, which this study had previously reported. It was like 20 to 30% higher than baseline levels. But you also, over a year of follow-up, because you didn't drop your testosterone, had similar cholesterol levels over time, and hemoglobin A1C, that's blood sugar levels over time, and other metabolic effects that actually were they were stable. You didn't have these negative metabolic effects. We do have information in others, in actually it's called a biochemical recurrent population. So PSA rising after primary treatment, but these patients don't have measurable prostate cancer on scans. We have information that if we're using these agents as single agents, we may have reasonable cancer control. It may not be as good as if we use them in combination, but it's pretty good. And so now having this cardiovascular type stability and these metabolic factors in maybe a more favorable state, I think this is something that may influence our decision making in the future. And Avrap, I know, or Avi, I know you probably haven't seen that data because it literally came out last week, but if you had the option to have patients on that kind of an approach, I imagine that this would be potentially a benefit from a cardiovascular risk perspective.
Yeah, for sure. I mean, if testosterone can be preserved, it definitely helps with the two things we talked about. So I think one of the things is um, uh, uh, you mentioned sort of the metabolic profile and its effect on it. And I think even without the darolutamide data, we'd know that what testosterone would do if it was present. And the other part where it helps is the skeletal muscle strength data, which we obviously showed that skeletal muscle strength at baseline and in general weakness leads to more adverse cardiovascular events at 1 year follow-up and even more beyond that. So I think there's definite benefit to all sort of approaches by which testosterone is preserved. But again, I sort of say with the caveat that making sure the first goal is to treat the prostate cancer and do the rest beyond that to sort of save quality and quantity of life.
I think when it comes to all of this, that's really the balance we're trying to meet or reach. And I think that that's going to be different for any individual person because they'll need to have more intensive cancer control and have to take the consequences from a cardiovascular perspective and then have to intervene in other ways through exercise, diet, perhaps medications to deal with those consequences. And then others may need less intensive cancer therapy, but may be able to sort of maintain some of these metabolic issues in a different way. So this is the conversation that's so important between patients and their doctors and their families to try to find that right balance.
All right, we're just about at the end of our Q&A time, but we have one last question in the chat that I want to get to in the lightning round for Dr. Ryan. We have a patient that was started on ADT and abiprednisone without a bone-modifying agent. 8 months, suffered a compression fracture, and only then did they get a DEXA scan and bone-modifying agent. Shouldn't they both have been ordered at the same time they went on ADT and abi?
So it depends on the setting. In hormone-sensitive disease, we don't have an established criterion for the use of the bone-targeted therapy. And in fact, we studied the use of them in the setting of metastatic untreated disease, and there was no significant benefit. In the setting of castration-resistant disease, yes, there's a clear benefit, and that would be considered to be standard of care. But a compression fracture is not necessarily a disease-related issue. It's a issue related to loss of bone density. And so really what you probably have in a setting like that is a patient who may have had pre-existing bone density issues that may have been accelerated by the ADT and the abi. And that's, the guidelines are a little bit unclear on that. I think it is good standard of care, even in primary care medicine, for men to get baseline bone mineral density scans and to be followed. Calcium and vitamin D, of course, is standard of care. So it remains a little bit unclear what is done in that setting, but one of the things we aspire to do is to get a good sense of bone health even before we start ADT.
Thank you all so much. This has been a really fantastic discussion, and we really appreciate your input today. So what we'll do now is we have the post-test poll, which Michelle is going to put up for us. Please do fill that out for us so that we can get a good sense of how well we hit our targets today. While you're doing that, since we are running a little short on time, I'm going to have you fill that out while I'm continuing to talk here, because I want to make you aware of another resource that we have available to you, which is our ECHO series on improving treatment in advanced prostate cancer. This is a series that was run last year over a course of 10 months, took a deep dive into this topic, and talked about a lot of different considerations, both the changing field of available therapeutics, imaging, management of survivorship and wellness, and lots of really great topics. So please do check that out. It was a really great series. I was there for most of the discussions. They were all very good. Beyond that, if you would like to stay in touch with us through the roundtable, we have our website, our LinkedIn, and a newsletter that you can sign up for at these locations. And then, of course, if you're interested in membership in the roundtable too, there's a place to apply for that on our website as well. Otherwise, please feel free to get in touch with us at our email address at npcrt@cancer.org. And with that, I'll give one last minute to finish up that quiz. But otherwise, thank you so much for your attendance and attention today. Hope this was really helpful in terms of your understanding of these important considerations in the treatment of advanced prostate cancer. One last thank you to our fantastic speakers and to our behind the scenes crew on the ACS and PCRT staff. So thank you all very much. Have a wonderful afternoon, and we'll see you next time.
Thank you, everyone.
Thank you, everyone.